Testing, testing. Test, test. I just handed it down. Oh, I'm sorry. Hi, I'm calling. I'm in the combinable conference room on 6, and I'm setting up a presentation. However, it won't show presenter mode for PowerPoint. I was wondering if you might know why. I have used it before. Yep. Oh. Okay, so now the presenter mode is showing up for the viewer, but not on the. There we go. Perfect. Okay, good. Good to note. All right, thank you. Yeah. Oh, sure. Yep, I'll write a note. All right, thank you. Bye. Learned a computer hack. Oh, I'm on phone now, yeah. I got it. Okay. I have a little magic button. So see, because this is what they're seeing. Okay. Right? And for virtual, but then you'll have this view. Do you have things that you'll be pointing to on the screen? Trying to point out to at all?
I guess I kind of,
Because if so, what I can do, this is something I recently learned. We can put, because sometimes I feel like the mouse can still be hidden, especially with a lighter background. So we can change the pointer option to laser pointer here and just keep it in the corner. And that way when you are pointing it out, and this will stay. Like as the slides advance, it'll stay in that mode. So then it's a little bit easier to see on the screen. But totally up to you if
no, it's fine. Yeah,
want
it's a good idea.
you can advance with the button here to move forward. It will go backwards as well. But again, the laser pointers with these screens, it doesn't work. And then we do have people virtual. So the best option is going to be to use your mouse here.
You'll probably just stand by the podium, which we see myself.
Kind of see the view that they're seeing. So the camera that's catching you.
Oh, the camera catches me in this presentation.
Yes. You'll be little on the screen, but you're on there. So if you be mindful
gestures
of and then the microphone will be on just to kind of catch sound throughout the room, but also more so for the virtual. For questions at the end, if they're being asked in the room, if you can repeat them, it's a little bit easier because not everyone, based on how they ask their questions, can't be heard for what they asked. And then Dr. Carroll will help moderate the online. I was like, yeah, when you sat there, I was like, yes, and you'll.
Dr. Konami's not going to be here.
Correct.
Okay.
And then I'm gonna grab the other laptop. We have someone that's like training right now that's using it, so I'm gonna snag that from her and then pull up the virtual for you. Did you want like a glass of water at all or anything?
Is it okay to enter a little early?
Yeah.
Okay. Yeah. All right. Well, I'm gonna move my stuff out of the way. Yeah. And it should be good. What I'm gonna do is I'm just
and start at 4:01, even though Dr. Kanamdi's not with us. We got to give the extra 1 minute for punctual group. All right, it is 4:01. So it gives me great pleasure to introduce today's Grand Round speaker. Dr. Engel, as many of you know, is definitely one of our top 2 second-year endocrine fellows here. She completed her medical school training at the Medical College of Wisconsin Regional Campus in Green Bay, and did, and her medicine residency here at the Medical College of Wisconsin, and we're very lucky to keep her on. And it's been my pleasure to have her as a fellow when I started here as program director. And we'll miss you in another 10 months. But she's going to talk to us today about the journey of the islet cell transplantation. So,
thank you for everyone for joining us today. The title today will be The Journey of Islet Cell Transplantation. Perhaps a better name would have been The Journey to Islet Cell Transplantation. I have no disclosures other than the fact that I am not a transplant surgeon or physician, so kind of just bear in mind that this is the endocrinologist perspective on transplant. So our objectives today, it's the advancement in the field from theory to reality, the indications for both islet cell and whole organ transplant, the outcomes of these transplants, and where is the science going from here. So how the talk will begin is we'll start with kind of the breakthrough in insulin and how that was the beginning of replacement therapy, moving into how insulin wasn't perfect, thinking about whole organ, and then why we got to islet cell itself. So kind of in the beginning, the first documented case of diabetes called honey urine was actually in 1550 BC by the Egyptians. Fast forwarding all the way to 1869, it was discovered by Paul Langerhans, the clusters of cells that we know as the islets that were responsible for draining the pancreatic secretions. About 20 years later, the idea that the pancreas played a role in diabetes was born after inducing the symptoms of diabetes in dogs following pancreatectomies. And then between 1901 and 1919, I guess you could say there was various interesting attempts to control hyperglycemia with various things like salt extracts, and pancreatic extracts. I guess as you can imagine, they didn't really work. It actually made some patients worse. Then, as we all know, in 1921, Banting and Best in the lab of McLeod, with the assistance of Dr. Collop, purified what is the original insulin that we use today. Within 1 year, this was given to a child dying of diabetes. And after the second attempt, they noticed an improvement in his blood sugars and symptoms of type 1 diabetes. Within the year, there was a growing demand for insulin, and the University of Toronto, which was where the lab was, gave Eli Lilly the rights to manufacture and distribute insulin free of charge for the first year. And then after that, Eli Lilly really took off with making insulin for the nation and the world, really. And then within the next year, the patent was sold for $1 per person to the University of Toronto, who then gave the rights to Eli Lilly. So over the past 100 years, insulin, as you can see from these newspaper clippings around the world, was felt to be the cure. However, as many of us know, it is a very useful tool in treating diabetes, both type 1 and type 2. However, it is far from perfect or the cure that we initially thought it was going to be. So this is just kind of an illustration of how all the way in 1869, we discovered that the pancreas was associated with diabetes. And now all the way in 2020, we have kind of our go-to insulin. So it was a long, hard journey, and yet we're still kind of on this path to perfecting our treatment of diabetes. So really in search of a cure continued. exogenous insulin remained a standard of care, but we continued to look for the physiologic mimic of the pancreas. We went down the road of CGMs, insulin pumps, which all have improved outcomes. However, as it was pointed out by the Diabetes Control and Compliance trial, being close enough isn't quite good enough because glucose homeostasis is really the true threshold of preventing the secondary complications of diabetes, which leads to multiple comorbidities and costs related to the disease. So there was continued thought of how can we mimic what the pancreas does, and this is where whole organ or islet cell transplants started to become more of a theory into thought. And like I said, despite all these advancements in the technology of diabetes, the disease itself is still plagued with hypoglycemia, hyperglycemia, and secondary complications. So from moving on to insulin to pancreatic transplant, within the past decade, the number of persons carrying the diagnosis of diabetes increased from 108 million to 422. In the US alone, this is about 10 to 15% of the population, 1% of which has type 1. And there was always this continued thought, like, how can we reestablish this endogenous insulin that is responsive to feedback? There was at times the development of insulin that responded to glucose levels, but it wasn't quite what we had hoped for. And then in the 60s, it became more implemented in trying to find this replacement therapy, such as cell, pancreas. And then in 1966, Drs. Kelly and Lahey performed the first pancreas transplant at the University of Minnesota. So although the first transplant was performed in 1966, it was not successful, unfortunately, and it took nearly 3 decades to really make a reliable whole organ transplant process. Namely, the main challenge was the immunosuppression. So although 48,000 transplants have been performed as of 2014, if you look at the numbers, there was only 9,000 performed from the first transplant through the mid-'80s. And really the reason why was the high rates of graft rejection. As patients found out that the transplants were a success, obviously no one was willing to undergo one. So really with the induction therapy of cyclosporin in 1983, moving into what we now use as our main immunotherapy, the tacrolimus and mycophenolate in the 90s, caused a significant increase in the interest again in transplant. As well as T-cell depleting agents also improved graft rejection rates, led to the increase in transplants overall. So with the advancement of the immunosuppression, there became more interest in what type of transplant we should perform. So there's 3 main types: simultaneous pancreas kidney transplant, abbreviated SPK, pancreas after kidney, PAK, and pancreas alone, PTA. About 80% of all transplants are simultaneous pancreas and kidney, for reasons I'll get to in a moment. Most patients undergoing transplant in the US have been historically type 1. However, going from 2016 to 2018, this number of type 2s has nearly doubled from 7.4 to 14%. And there's also a few number of patients that are cystic fibrosis with pancreatic insufficiency, or those status post total pancreatectomy, also receiving pancreas transplants. But today's talk will mostly focus on type 1. So this is just a graph kind of walking you through who gets what transplant. So if we look to the left of the figure, the first thing you have to think about in the pancreas transplant is the kidney, namely because the immunosuppression is nephrotoxic. So you don't want to give a pancreas to someone who has poor kidney function because you'll kind of end up with more problems than you started with. So the first thing that's reviewed is GFR. So anyone with a low GFR less than 20 who really has a life expectancy less than 1 year on dialysis will receive, or be put on the list to receive, a simultaneous kidney and pancreas. Whereas a person that can wait more than 1 year or can receive a donor from an organ from 2 different donors will then receive pancreas after kidney. And then the fewest number of transplants are actually pancreas alone. These patients are screened for renal function, and not only do they have to have normal renal function, but no indication that renal function will decline in the near future, because we need to take into account the immunosuppression. And this usually is patients with type 1 diabetes who have severe and frequent hypoglycemia, and then ketoacidosis or complications of diabetes. So really, the criteria for pancreatic transplantation, I think most of us know the UNOS is kind of like the main the organization for transplant. So it used to be having a diagnosis of type 1 was key. However, this isn't the case anymore. And strictly the criteria are the UNOS, which are either you have to be on insulin therapy with absolute deficiency of endogenous insulin, as indicated by a C-peptide less than 2, or on insulin therapy, and the C-peptide can be greater than 2, but your BMI has to be less than 28. So after you meet these criteria, there is 8 more selection criteria that used to be overall absolute, and now in the past 5 years have become fairly relative depending on the transplant center or even the state. So the first 3 being age, BMI, and renal function. I think we've really talked on renal function, namely this comes down to what type of transplant you could be eligible for. However, there was always concerns with age, meaning that more advanced age would result in higher risk of graft failure or complication. But despite having higher mortality compared to a younger patient, the patient that was more advanced age that received a transplant still was better than someone who remained on dialysis or did not receive the transplant. And they're really looking at more, is it a score of frailty versus absolute age that should be correlated with pancreatic transplant outcomes. And there was an interesting study done by Lamoni of patients over the age of 70 that showed increased mortality. However, this was followed up with an additional study that showed that really at 5 years, patients at age 50 were comparable to those at 35. Also taking into account BMI, it was relatively recently that BMI became more relative of a contraindication. And so it used to be that more of an absolute that BMI over 30 was not a transplant candidate due to the risk of graft failure and then death following transplant. However, there's newer data supporting that perhaps patients should be sent to bariatric surgery and not been told hard no on the transplant, but go to bariatric first and then come for an organ transplant. I guess one of the most interesting selection criteria I discovered was marijuana use. I didn't, take this into account. It's become actually pretty debated depending on the state. So legalization of marijuana is state-based, and so there's varied opinions based upon some of the states or the transplant centers themselves. And kind of like a common theme of my entire presentation is basically the outcome and the opinion is mixed. So that plays into a part with marijuana use. Also, history of malignancy has also been debated. I guess you could say the standard was that remission had to be between 2 and 5 years. However, newer data is kind of challenging this traditional practice. There was a study by Dahl et al. In Norway that concluded that there was no difference in outcome, even if remission was less than 1 year. However, there was a fairly large database retrospective study between 2004 and 2016 of UNOS data that observed that there was actually increased mortality and graft failure if remission was less than 2 years. And then there was an additional study a following year that looked at that there was no difference in thyroid cancer patients if the remission was less than 1 year and receiving pancreas transplant. And lastly, it goes without saying that taking into account cardiovascular history is essential due to the calcification of the vascular system playing a role in graft rejection. Okay, so like I said earlier, my only experience with transplant surgery was my 2 months in residency, so I'm not exactly sure the nature of the surgery, but this graft image kind of illustrates the complexity of the procedure, which is one of the reasons there continue to be interest in doing islet cell transplant due to the less invasive nature of islet cell versus a whole organ. So 90% of all pancreas transplants are performed with the systemic venous system drainage being connected to the donor portal vein and then the iliac vein. So really, what's the number of transplants, whole organ transplants in the US? Like I said earlier, the majority are simultaneous kidney and pancreas transplants. One interesting thing to note, as our immunosuppression was getting better in the US, the number of transplants was also downtrending. So between 2005 and 2014, there was a decrease of nearly 20% of whole organ transplants. From what I had read, there wasn't really conclusive data as to why this number was decreasing. There was a couple theories and thoughts behind it. One being that maybe as endocrinologists, we're just getting so good at medical management with advancement of CGMs and pumps. There's also a decline in donor quality. So if you think about one statistic showing that in the past decade, diabetes went from 100 million to 400 million. So as kind of supply and demand, the number of patients with diabetes went up, the supply of our pancreas donors went down, and also demand. Makes sense. And then lack of consistent referrals, as well as one interesting thought was that some of our transplant surgeons were aging out, meaning that more younger physicians aren't going into transplant medicine as there is retiring physicians. However, in 2014, the volume continued to increase, with the most transplants ever being performed in 1 year being over 1,000 in 2019. So really breaking down transplants overall, figure A is looking at who is getting what type of transplant. Like I've said a couple times, simultaneous is the most common pancreas kidney transplant, with pancreas after and pancreas alone being fairly similar numbers. Graph B, looking at who's receiving these whole organ transplants. Type 1 patients are by far outnumbering everyone else. However, the green line, you can see that type 2 patients are on the rise. And looking at graph C, what is the age of the majority of our transplant recipients? That would be the pink line, ages 35 to 44. And then majority of patients receiving transplant are white, as indicated in graph D. However, the number of Black, Asian, and Hispanic numbers are also rising. So with all this being said, what is really the outcome of these transplants? Is it worth our while? And as of the mid-1980s, survival of the graft in the pancreas wasn't so good. It was 91% patient survival and 72% survival of the graft itself in 1 year. These numbers decreased to 84% and 62% at 3 years. Also interesting is that it wasn't until 2019 that we came to a consensus of what really defined graft survival. So in the mid-80s, graft survival at that time was defined as insulin independence, which is, I'll get to in a moment, not the case anymore. In 2012, graft survival continued to improve, with best survival at 5 years being the patients receiving simultaneous pancreas and kidney. And then, unfortunately, between 2012 and 2016, there seemed to be a decrease in 5-year graft survival of pancreas after kidney and pancreas alone, and we're not exactly sure why this is the case. So just briefly looking at graft failure within the first 90 days, these numbers are improving from 2008 to the present, with overall loss decreasing from 11.7 to 6.2, and also simultaneous pancreas kidney transplants. The graft failure at 5 years, or graft failure at 1 year is 4%, 5 years 13.4, and 10 years increasing to 34.6. So kind of go back to what is defined as failure today. So this data, one thing to note is that these two graphs are compromised by the fact that they combined data in early 2019 that did not include the new criteria for what defines failure. So I guess take these with a grain of salt, because the article was already completed and they decided to change the criteria of what defined failure. So currently failure is defined as one of 5 things occurs. 1, the pancreas is removed for any reason, a recipient of an organ re-registers, or they go on the registry for islet cell, or the recipient dies from any cause, or their total use of insulin is greater than 0.5 units per kilogram for 90 consecutive days. So if the graft survives, they started to look at does it improve patient mortality? And unfortunately, this data was also a little mixed. The graph on the left showed that there was no difference in mortality between those that received transplant versus those on the wait list. However, a retrospective study of almost 14,000 patients from the UNOS registry found that the relative risk of mortality was 0.4, so it was less than those on the wait list. And then there was an additional analysis of the UNOS registry by Venstrom et al. That found a disadvantage for those receiving transplant. Unfortunately, the study done by Venstrom was then redone to include the new criteria of what defined graft failure. And then that data then found that transplant did have a favorable effect on mortality. So the big thing we always ask ourselves, like, is the transplant worth it? Is it better to keep our patients on standard therapy, or is there any beneficial impact on diabetes itself? So as we know by the Diabetes Control and Complications trial, intensive glycemic control is the clear benefit to preventing microvascular complications. So in theory, restoring our euglycemia through an organ transplant should reduce these complications. And of course, there's conflicting results if this is actually true. The main focus has been retinopathy and nephropathy. So in regards to nephropathy, despite improvements of glomerular function, there is concerns that the nephrotoxic effects of immunosuppression may lead to worsening renal outcomes. In regards to retinopathy, they have found favorable effects if someone has early or mild retinopathy. However, if it's more advanced, there hasn't been any proven positive outcomes. And then in regards to cardiovascular outcomes, there has been favorable reduction in risk and events through improvement of microangina. And then neuropathy, unfortunately, has received the least attention. However, there has been one study that proved that sensory and motor, as measured by conduction studies, has improved with pancreas transplant. Another thought that crosses our mind is that what's the cost? Is standard therapy more or less expensive than a whole organ? So the major takeaway is in the bottom right corner. Standard of care is more expensive compared to a pancreas transplant in a 10-year span. And then looking at our other images, so the dark gray is cost saving, medium gray is cost effective, and the light gray is not cost effective. So the three categories we kind of looked at is the top one is the overall cost of a transplant cost effective. So if the entire cost is less than about $93,000, it was cost saving. If it was less than $184,000, it was cost effective. At any point that the cost of the patient's transplant exceeded this, it was less cost effective than standard care. Our second line looks at the follow-up cost of our transplant patients. So if the follow-up cost was kept below about $21,000, it was cost saving. However, if it exceeded about $31,000, it was more expensive than standard of care. And lastly, taking into account these patients are on immunosuppression. If the immunosuppression ever exceeded about $16,800, it was more expensive than standard treatment of diabetes. However, if we were able to maintain this cost less than about $6,000 or less than $7,000, it was cost saving. So what really led to the interest in islet cell? So islet cell and pancreas whole organ transplants were both in thought at the same time. However, whole organ, our technology was more able to allow us to do an organ versus cells in the 60s. And so as time progressed, there was more and more interest in reducing the cost of pancreas transplants with just doing cells. And also there was a significant limited amount of donors. And one benefit of islet cell is that a pancreas that was denied for whole organ could then be used for cell harvesting, so it allows for a greater number of donors. Largely what we're limited by is that we have over 400 million patients with diabetes and just not enough whole organs to go around. Also, it's a very complex procedure, as you saw by that one graph, lots of sutures and reconnecting of things. And also, a whole organ transplant is an invasive procedure with significant risk. So moving from our pancreas to our islet cell transplantation, really the one benefit of islet is the greater flexibility in terms of regeneration, manipulation, and immune isolation compared to our whole organ. And for the past 40 years, there's been a significant interest in islet cell. However, we've been pretty hopeful, although it seems to be pretty elusive from restoration of euglycemia in patients. So before we can really talk about what islet cell transplantation is, I just briefly wanted to review what is an islet cell. So 2% of our pancreas is islets, which regulate our glucose metabolism. This is about 1 million cells, or 1 million islets, and the 4 distinct cells we think of are alpha, beta, delta, and ellipsin. So further breaking this down, about 10% of the islet cell is delta cells, which produce somatostatin, glucagon, and pancreatic polypeptide. Another 15 to 20% are alpha cells that produce glucagon, which is then converted to glucose eventually by the liver. And then 68% of cells are beta, which produce proinsulin, later broken down into insulin and C-peptide. So this is just really trying to show the harmony between all these cells, which adds to the complexity of islet cell transplant, trying to maintain that harmonious relationship between all the cells. So in a nutshell, islet cell transplantation is essentially isolating donor cells and then taking these cells and purifying them to remove any fragments, and then taking these cells and infusing them into the hepatic portal vein. It sounds simple, to say the least, but unfortunately, it's not the case. And then these cells are supposedly supposed to engraft within the portal vein in the liver, which is one of the downfalls of islet cell transplantation, that you don't have this immediate impact on improving hyper and hypoglycemia. So our early attempts began in the 1960s to try to extract islet cells from tissue. There was some initial success with rats and guinea pigs, and then it was in 1980 that the first human transplants were successful, with 7 patients status post renal transplant, and then 3 patients status post at pancreatectomy. Only 2 out of these 10 patients were successful and remained off insulin for 1 year. Kind of like disappointing outcomes. It was the first ever proof of the theory that islet cell transplantation could work in humans. And then throughout the 1980s, there was continued barriers with transplant for islet cell. Namely, there was a lack of consistent methods of isolating these cells. So each lab was kind of doing a little bit of their own thing. And then there was also lack of effective and non-toxic immunosuppression. And then again, donor shortages. Although the initial trials with islet cell didn't go quite well, there was still continued piqued interest. And so the International Islet Transplant Registry reported 1-year islet graft success of 41% and 11% remaining independent for 1 year in between 1990 and 1999. But it really wasn't until the birth of the Edmonton Protocol in 2000 that clinical islet cell success was actually thought to be achievable on a large scale. And then later in 2005, Herring et al. Refined the induction of T-cell depleting antibody therapy, which led to further success with islet cell transplant. It really was from here that islet cell transplant was thought to be more feasible on a large scale. So with the Edmonton Protocol and Herring's research, insulin independence improved from 27% to actually 44% with both of these methods. So this kind of moves us into the modern era of what islet cell transplantation is looking like. So within this graph, it kind of gives us an image of really how the cells are isolated, which I'll go into further detail in a moment. So we have our whole organ, and then we isolate the cells and transplant. So really looking at each of these steps in more detail, islet isolation methods have improved. However, they're not perfect because about 50% of the cells that we initially have to harvest get damaged. So we started with about 1 million, if you think back. So now we're left with half of those. And so the pancreas itself is distended in cold enzyme solution and digested to break down cells, and then purified by continuous density gradient. Cells are then liberated, and then the best cells essentially are selected for transplantation. This process is far from perfect because so many of the cells are damaged, and there's also a little inconsistency and variability in the tissue of the tissue density, as well as significant oxidative and ischemic stress to the cells. Then moving on to the engraftment, one benefit of islet cell is the fact that it is a local anesthetic procedure done by IR versus an open abdominal procedure. And so these cells are infused, and then only 25 to 50% of the cells infused survive. The immediate loss is thought to due to an immediate inflammatory reaction and then natural killer T cells. So with those two causing cell death, there was a piqued interest in how can these two things be reduced, and namely it's been achieved through immunosuppression and improvement in immunosuppression. And lastly, just briefly on immunosuppression, I know this really wouldn't apply to most of us, but it really has been immunosuppression leading to the improvement of islet cell transplantation with Interocept and alemtuzumab, as well as maintenance with tacro and mycophenolate, as well as T-cell depleting antibody that could suppress autoimmunity is still undergoing research. Also, one new thing in immunosuppression is using microcapsulation to then have to decrease our need for immunosuppression. Okay, so who really is a candidate for islet cell transplantation? Overall, the criteria for who gets a whole organ or who gets islet cell is fairly similar. The main criteria is patients with severe recurrent hypoglycemia. The one big limiting factor as to who might get what type of transplant is the location you're in. So in the US, islet cell transplant is still considered an investigational new drug, whereas in Canada and Europe, it's an accessible therapy. And then within the US itself, you're more likely to receive a whole organ if you're near a pancreas transplant center versus more of a larger institution that might have investigational new drugs. So islet cell transplant is currently only offered mostly at highly specialized transplant centers. And most of the patients being selected are those with type 1 diabetes that's with severe recurrent hypoglycemia, and they also have to have unawareness of this hypoglycemia. And then the main goal of most of these centers is to try to improve glycemic control, eliminate hypoglycemia, and overall achieve possibly insulin independence. So what have been the outcomes? So between 1999 and 2005, there was over 1,000 patients that have undergone islet cell infusions. The initial outcomes were not what we had hoped for, but they're improving. So between 1999 and 2002, insulin independence was about 27%. This increased to 44% by 2010. However, these numbers at that time were not as good as whole organ, which had a 3-year insulin independence of 69 to 85%. So one thing I kind of want to discuss today is, with there being a lot of inconsistency and differences in outcomes of whole organ and islet cell, this one study by Engel et al. Really looked at where is islet cell today. So what I liked about this study was that it was an analysis of 10 years of outcomes, whereas previous reports were based upon single cases or small series reports. So what this study really sought to look at was the evaluation of hypoglycemia, which is one of the main indications for islet cell transplant. Did islet cell actually improve hypoglycemic events? So I kind of tried to highlight it here with the 2 green arrows. As you can see, as the primary outcome sought to define was that, does hypoglycemia improve? And so at 1 year, 5 years, and 10 years, patients that received islet cell did have a reduction or favorable outcome in hypoglycemic events. So hypoglycemic event was considered, primary outcome was defined as no insulin and an A1C of 6.5%. And this study did show that this was a favorable primary outcome. Secondary outcomes looked at patient survival, yearly incidence of hypoglycemia, graft function, C-peptide production, and then daily CGM profile. So the median incidence of hypoglycemia did decrease from 2 events per year to 0, and then all metabolic parameters such as A1C, daily exogenous insulin use did improve. However, from year 1 to year 10, these numbers did deteriorate with time. And overall, over the course of 10 years, 75% of patients maintained graft function and 28% maintained or met their primary outcome, which was insulin independence and an A1C under 6.5. Just to highlight a couple more features of this study, Graph A showed that our patients remained off of insulin with an A1C less than 6.5, was 39% at 5 years and 28% at 10 years. These percentages, as indicated by figure B, did not differ between islet cell alone, which is ITA, or islet cell after kidney. Then in graph C, I think it goes without saying, those that had optimal graft function had better insulin independence. Then looking at graph D, they just wanted to look at graft survival, which was 82% at 5 years and 78% at 10 years for the entire group, as noted by graph D. And then graft survival in image E did not differ at 5 years versus 10 years, depending on the type of transplant. And one other thing they kind of thought to look at was the continued thought about, does immunosuppression make kidney function worse? And so in both of these groups, the islet cell alone and then islet cell after a kidney, both had decline in renal function over the course of 10 years. So really thinking, what would be better for a patient, whole organ versus islet cell? You kind of take into account the differences between the two. Whole organ is a clinical procedure. It's a major surgery. However, you do achieve higher percentage of insulin independence, and also it's a more immediate response, whereas an islet cell, it's considered a minor procedure. However, there's a delayed onset of function. And then there is more availability for potential donors. However, in the US, this is still considered clinical research. So really, what is the future of islet cell? There's two main things that are currently being looked at. First, is there any alternative site for transplant? So the liver isn't an ideal spot due to the significant graft lost. However, and there's poor access for biopsy, and you can't remove the graft after the procedure is done. So they're currently looking at the safety and feasibility of using the bone marrow, momentum, microcapsulation, or any intraperitoneal space. So far, the results have not been what we had been hoping for, but still promising in regards to microcapsulation. Also looking for alternative sources of cells due to the donor shortage and increasing rise in patients with diabetes. There's been some success with stem cells as well as porcine islet cell transplants. Although the alternative sites and the alternative sources have been kind of more hindered by thrombus than what would be expected, and also poor immune response and rejection. So kind of looking at porcine cells, this was thought to be initially a very good alternative because the initial insulin was derived from porcine, and then porcine islets are more similar to human than other sources because the beta cell has the same set point as the human beta cell response for glucose. And then there's really a kind of an unlimited supply of these cells. And then different than stem cell, there seems to be no ethical debate about using them. One thing that's been a theoretical challenge to porcine cells is this concern for PERV, which has not been occurring in humans yet, but has occurred in some rodent models. And so stem cell, also thought to be a feasible option first achieved in 2014. And they were looking at making functional beta cells. However, one challenge with the stem cells is that the functional beta cells made are not as robust as the beta cells derived from the pancreas itself. So we're in the phase 1, phase 2 trials at multi-centers in Alberta, Canada, looking at human embryonic stem cells being implanted in the differentiation stage of endocrine progenitors, and then possibly putting these in microcapsulation devices, because that would reduce our need for immunosuppression. So there's been a lot of challenges with the stem cells. Like I said, the stem cell-derived beta cells do not have the same robust physiological response as a beta cell derived from the pancreas directly. Although they're hopeful for less cost with stem cells, right now it is more costly than using pancreatic cells directly from the pancreas. And there still needs to be further discussion about what would be the best site for stem cells. And then the last thing that it's kind of challenged by is adequate blood supply, because they discovered that these cells need more supply than beta cells derived from the pancreas. And just lastly, kind of looking at where are we going with the stem cells. There's 2 ongoing trials, one by ViaCyte and the other by SEMA Vertex. Both have started to do recruitment in the first phases of stem cell trials in patients with type 1 diabetes. The first patient receiving beta cells derived from stem cells in February 2022. And lastly, these are just some of the key ongoing trials. As you can see, most of these are occurring at University of Alberta and University of Minnesota, kind of where the birth of both pancreatic transplant and islet cell occurred.
Great talk. So we'll take any questions if anybody in the room, or I will also take questions in the chat box, or if you want to unmute yourself if you're virtually viewing, feel free to ask questions now.
So if I could probably go on for about 3 hours, you don't want to listen to me. So islet transplantation really didn't start in Edmonton. It started in Washington University in St. Louis. Did you run across the name Paul Lacey? Yeah, Paul was tremendous. I had the good fortune of living next to Paul Lacey for 5 years, and was in the building when that first successful transplant took place with Paul Smith. It was an amazing, extraordinary time. WashU kicked in $10 million a month after the successful transplant, and they started the GMP facility about a mile from campus. It was incredible. I know all the boys in Edmonton real well as well, Shapiro and Greg Corbett, Jonathan Lake, and those guys. The big improvement in islet transplantation was liberase. The collagenase used to isolate the islets, that was the key, because everybody used a different collagenase, and so you do beat up the islets. When I think of islet transplantation now, you hit on some of the really important things, right? So vascularity is critical, and the reason why in the liver we don't have successful engraftment is they just don't vascularize well, and that's a real issue. If you think of, you guys are the endocrinologists, not me, but when you think about the human pancreas, you mentioned 2% of the pancreas is endocrine, right? Do you know what the blood flow into that 2% of the tissues?
Like 90% of all blood flow.
Yeah, 90% of the blood that goes to the pancreas goes to the islet, and we're all sitting here thinking, thank God, right? Because somebody where it needs to go, and glucagon out where it needs to go. And so that's the trouble with transplant right now, and it has been for a long time. And the successful ones are because of the other issue that we don't talk about, you didn't find anywhere in your reading, other than they talk about the quality of the islet, right? And they talk about islet stress during isolation. What is the mode of death for most patients who provide the organs? Did you see that at all?
Death?
Yeah, right? So these are cadaver-donated organs. So how do those individuals die? Right? So most of it's brain death. And do you know what happens during brain death? What's that?
It's a low flow state.
It's a low flow state, but there's a cytokine storm, right? There's that huge cytokine storm, and it goes back to that blood flow. 90% of the blood goes to 2% of the tissues, and it's full of cytokines that turn on a stress response in the beta cell. And I have spent the better part of 20 years trying to convince the transplantation community that this is a big issue. And I've been completely unsuccessful. When you stress a beta cell, it doesn't respond to anything. And there's a paper that Jennifer Stanzel in the Biochem department recently published and shows that not only do they not respond, they de-differentiate. All of those endocrine defining genes go away, which will, in the end, contribute to the lack of success. Right? Super cool stuff, though. I bet you when you were reading about this, it was super cool. Do we do any of this here?
Not to my knowledge.
So there was a guy. Yeah, medicine.
In
is-
Madison.
In Madison, yeah, John, yeah, we was there. I just talked to John
Yeah.
today. So there was a guy in surgery who was going to do islet isolation.
Dr. Adams.
Is that who it
Was
was?
it Mark Adams?
I don't
Who was
remember.
the one that he passed away a while ago?
It was a young kid. He was a fellow who was going to do. This was probably
Recent?
10 years ago.
Oh.
It's really sad. I can't remember his name. But auto transplants actually. Did you run the numbers, or did you say anything about auto transplants?
No, I focus more on like the beginning of islet and then
Yeah.
stem cell.
So the auto transplants are actually even more successful because the immunosuppression goes away, and that's really helpful as well. But it's fascinating. So what do you think in the end? Is pancreatic transplants the way to go? Islet cell
I
transplants?
think if
Or
we
is
could get islet cell more
Yeah.
successful, I think
If you could get it more.
if it was successful, I think right now it's not something I would try to convince a patient to do because the success isn't, like if I wouldn't do it, I wouldn't try to convince someone else to do it.
yeah, that's important. So I agree. So Sutherland at Minnesota is an interesting guy because he would argue all day long that pancreatic transplant's the way to go. We should do this all the time. And one of my last times there, I was actually at the bar waiting for my brother-in-law, and one of the patients, one of the recipients' spouses was in the bar. We sat and talked for 2 hours. It was a super cool experience, right, to meet somebody, and his wife had just had the transplant. It is really a difficult surgery. Really challenging surgery, and really painful for the patients. It is not an easy procedure.
I think it's also like riddled with leaks. There's tons of leaks because you can see in that picture, like we're connecting this to this to this. I mean, eventually you're gonna get a leak, and that's usually the
Have you ever
biggest
tried to take a pancreas out of a rodent, or even, I'm probably not a
Yeah.
pancreas surgeon.
not a
Yeah.
rat, not a rodent.
Do you know how hard it is to get a pancreas out without causing leaks? Holy fuck.
Our old surgery chairman had a saying about the pancreas, but we won't use it here. About that you don't mess with the pancreas.
Yeah, right, you don't want to touch it, you don't want pancreatitis. It's really challenging. So I think you're right about islet transplant. So then it becomes a question. This is the big question for all of you guys, right? Do you want to treat your patients with an islet transplant, or do you want to do normal standard therapy? What's better in the end?
I guess one benefit to the islet cell, it's less invasive than full organ. So if it was more successful or more mainstream, you could do islet cell. And if it fails, I guess you're not out a major surgery or significant complications of a whole organ. You gave islet cell a chance, you did maybe the encapsulation or something, and then it failed. You're not any worse off than what you had.
So, but what about comparing an islet transplant versus just standard protocol for treatment? That's really the question, right? And this is, and that's the toughest question to answer. Is it better for your patients to take insulin and with the pump in terms of complications, or is the islet cell transplant the way to go? Because most after 3 years are back on insulin. I know it's low dose insulin, it's probably once a day.
Also with islet cell, you have to be on immunosuppression. Your immunosuppression's without risk, and you have to start thinking about the nephrotoxic effects of tacrolimus.
Or the fact that most of those drugs still inhibit insulin secretion as well. Did you see that at all in your?
Yeah. They're non-diabetogenic, and they're also nephrotoxic. And
Yeah.
we're trying to use this to treat the previous problem.
It's super challenging, right? This is a super hard problem that sounded so I still remember Paul Ace the first time I met him, and we talked about islet transplantation. It's going to be the cure, and it's going to be simple. We're going to be able to do this. I used to meet with David Sharp, who's the surgeon on the Jim Shapiro, last few days. And David and I would meet almost every Saturday morning, and just so hard to crack all of these things. And that's why we haven't been successful after 40 years of this, right? So the islet encapsulation you talk about is a recent phenomenon.
I think it seems to be what people say is going to be more promising because it requires less immunosuppression.
So explain to me how you get the vasculature to the encapsulation.
I don't know.
It depends if you invested in biocide or not.
No, I didn't. So you know what? So Biocide has a way actually to do it. That's kind of interesting and innovative. But that whole program of Biocide requires those cells to continue to grow, and you're gonna have to replace cartridges.
Yeah, a lot of the articles said like they're still trying to find the best vascular site, which just leads me to believe that they haven't been successful.
So Paul was doing encapsulation in the late 80s, early 90s already. They were using these allogeneic big tubes, and they were putting them in. And the original thought was to encapsulate and just inject them into the peritoneum. Right, and they slosh around all day and never right. It is that's why they ended up at the liver. And then the last part of all this, did you run across the name Camilo Ricordi? Camilo Ricordi. He is the individual who allowed this whole field to go. So Paul developed the first protocol to isolate islets. If any of you are interested, come to my lab. You can see the original microscope that Paul used to count islets. We still use it today. He bought it when he first joined WashU in 1963, and it's in operation today. And the wrist shaker that he developed to isolate the islets with collagenase we use on a daily basis, and that's probably 40 years old as well, which is crazy. Camilo developed the Ricordi chamber. And that was the chamber that they put the pancreas in with these steel balls and forced flow of fluid as the collagenase, which turned out to be the liberase, which is Guy McCarthy and Lilly made, that would chew up the pancreas, and as the pancreas would break apart, it would run through mesh filters, and then the islets would come out. One of the challenges it's really crazy, right? How this is all done, and it's a big crazy procedure. They had a whole floor blocked off of WashU. In the end, you get these islets, and we talked about purified islet cells. I will tell you, we just got a batch of human islets last week from David's company. David Sharp now runs a company that provides them. They tell you they send you 10,000 islets. When we actually pick out the good, clean, pure islets, we get about 1,000. So that's the 10,000 is what they describe as the purified islet material they transplant. And we would say that maybe 1,000 of those are functional. It's still super hard to get the tissue. We're going to get there though, I guarantee. It's super fun, but we will get there.
John?
Yeah.
It's Herschel. I really enjoyed listening to this. I think the biggest mistake I ever made was learning how to do islet cells from you, because it's a nightmare. But I have a former student who is was trying to make humanized pig for kidney transplant and liver transplant. And, this has been going on for a while. You know a lot more about it than me. But, they say they're close and then nothing. And then they say they're close and then nothing. And then you probably read the New York Times. Apparently there was a company that was trying to make hearts or something, and it was like some big disaster. So I'm interested in everybody's opinion about the probability of a humanized pig pancreas to solve at least some of the cytokine storm problem that you're talking about.
So you mentioned Ashley Bernard Herring. So that's what Bernard's doing, Herschel, is working on the humanized pig, and they haven't gotten there yet. I know Bernard very well as well, and there are a lot of challenges. So pig islets are really, really hard to work with because they fall apart instantly during the isolation. And that's one of the big, I know you read that they're just like human islets. They're not. They're really difficult to work with, and they fall apart pretty readily. What you're reading papers in reality is something I think the biggest worry with pig, and now in 2022, the biggest worry with pig is all the viruses that come through that we don't.
So they did
Yeah,
mention.
that's the problem they're having. The kidneys are transplanting beautifully. They put them in the ICU patients. The problem is they wind up getting positive xenoviruses, and they apparently, in like 40 generations of pigs raised in a sterile environment, they cannot get rid of these viruses.
That has been that's why Bernard struggled as well. That Schultz Diabetes Center at Minnesota, when that was the Best Buy family that donated the money to build that. When they donated the money, Bernard promised within 2 to 4 years they'd be in humans with pig islets, and they still haven't made it. And that was 2008, I believe. So I don't know the answer, Herschel. Like this is the challenge, is the viruses.
Great. Any other questions for Ashley before we call it an afternoon? All right. Thank